sort of come with a treatment plan. Maybe you can elaborate that on that, please, if you can.
Yeah, I think, of course, there's realities that go from an extreme situation where the doctor's not even present and a signature machine is being used to replace the physician, because that's going on out there, to physicians that are documenting their notes relatively well. This issue of follow-up, I think, is a tricky one, because, I mean, I practice internal medicine for 25 years. I've been doing cannabis medicine solely for the last 4 years, and follow-up just takes a different course. And depending what the patient's needs are, their age, the medical care that they have that I've reviewed, often discussions with their doctor, I don't feel that I necessarily have to see every single cannabis patient prior to their year renewal. I mean, if somebody's seeing their regular physician and there's been communication, people don't need to follow up, every 3 months, 6 months with every specialist. And pain, although it's certainly a huge topic, it's from by far not the most important thing that I end up using cannabis for in my practice. Probably the single most common thing is anxiety and insomnia, and which are conditions that are kind of laughed at, but when you consider, I mean, during the 2.5 decades that I was practicing internal medicine, I partly left because I got tired of the frustration of writing another benzo or opiate prescription when I felt it was going to get abused, and that it seemed that this is an example of the medicine of cannabis. This is the plant. It makes no sense. I mean, I think everybody's seen this plant. Very few of you have seen a tincture, and these are extracted cannabinoids into alcohol, and then we put it to glycerin, and the alcohol is extracted. And there's lots of legal issues and fears about it, but as a practicing physician, I firmly believe that as a non-smoking means, which it has to be, that tincture medicine is 4,000 years old. All of our major pharmaceutical companies were using this from the late 1800s through 1940 when it became illegal. And people are learning a lot about this, and the other advantages of a tincture is that, well, in addition to avoiding smoking, you get to dose it. I mean, you can actually have predictable doses. And, several drops that usually treats pain or anxiety for 6 to 8 hours. And the only side effects that I've ever seen, I had 2 patients that called me up, or their spouse called up with just uncontrollable laughter that went on. I'm serious. One patient brought the tincture in and was showing it to me, and we had to call the spouse to come pick her up because she couldn't drive safely because of the laughter. But do I think cannabis medicine is the answer for everybody, for everything? Of course not. But do I think for anxiety, insomnia, and pain that it's something very reasonable to start with? Absolutely. And the recent survey that I did with several thousands of my patients is beginning to show data that approximately, and again, these aren't double-blind studies, we can't do them, that over a typical year, a patient that's on benzo or a patient that's on some opiate reduces that dose by 65%. That's huge, and we are going to continue doing, this, type of work, and that's where I see medical cannabis heading. It's not. And just one point about scheduling. I feel a little differently about the whole scheduling issue. I mean, if you took all the pills in the physician desk reference and lined them up and looked at them around this building, and then again put 1 or 2 of these at the end, there's nothing that would look like a plant. I don't see how a plant can be scheduled. And to me, we don't want to change this plant to Schedule 3, because then we're locking ourselves in with pharma forever for pharmaceutical with pharmaceutical type cannabis medications, because I seriously doubt that it's going to be okay for me to write, smoking 2 puffs of a sour diesel every 2 hours is not going to happen, and dispense 1/8. It's not. That'll never be medical cannabis. The edibles, by the way, will never be medical cannabis in my opinion, because an edible and this is one of the most important points I think gets missed by most patients and most dispensaries where patients go. An edible, whether it's a sativa, and if we have time, I'd be happy to talk about the different types of strains, but regardless of the type of strain, once it hits your stomach, it's going to have to go the enteropathic route, and it's metabolized in a way that the 11-hydroxy delta THC is altered.
I was going to ask a question, I'm sorry.
Oh.
But I'll wait till you're done talking.
Yeah. And it becomes a very, very, very long acting. The half-life increases by about 5 times, and it's more of a psychotic, stony. I mean, it's a very unpredictable ride, and it's a ride. I mean, and I tell patients that. The most successful patients are, in my practice, are like 80-year-old women who can take a little tiny piece, eat it, sip some tea, wait an hour. But probably very few people in this room can do that, and they make the edibles taste great, and people eat too much, and they have horrible experiences, about at least in 20% of the time. So, although sometimes it's not a popular view in the cannabis world, I'm not a big fan of edibles. So smoking is smoking. Vaporizing is great because you're able to activate the cannabis at a lower temperature, 350 degrees, rather than 1250, so it's just a mist. So it has that advantage on the lungs, but it doesn't have any advantage as far as dosing the medication. You have a big bag of vapor, how do you possibly know what the dose is? It's just the same as taking a puff and saying you know that every puff is the same. Well, I could give you 20 reasons why every puff is different. So that's what's exciting to me. And in addition to working with tinctures, where I see a big part of the future is in analytic cannabis laboratories. And it's time that we really seriously are given the ability to study this. There's a very short story that I feel I just have to tell. It's a old joke where a professor is studying this frog's ability to jump in Calaveras County. And he keeps his book and his pencil, and every day he removes a leg of the frog and see how far it jumps, and I'll go through it quickly. Finally, he gets down to the last leg, and he says, jump, jump. Frog doesn't jump, and he writes down, after removing 4th leg, frog becomes deaf. So we are making conclusions about cannabis that I know many are wrong. THC is not the main thing that gets us stoned. It's terpenes. I've personally smoked them and can tell you that the terpenes in cannabis are probably where the biggest information is going to lie. Cannabidiol, CBD, is my guess going to be the molecule of the century. Not only does it prevent metastases from breast cancer, it's showing injectable glioblastomas in Israel and in Spain, shrinkage, but it's a way to, in this particular tincture, for example, has a bit more CBD, and this is the future of these tinctures, so the patients do not get stoned. Their pain goes away, and they just feel normal. Their anxiety goes away, and they just feel normal. And it's very, very exciting.
Any questions?